From MicrobeTV, this is Infectious Disease Puscast, episode 93, recorded on Monday, November 10th, 2025. Hello, everyone. I'm Dr. Daniel Griffin. I'm joining everyone from Toronto, the American Society of Tropical Medicine and Hygiene meeting. And joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. So, Daniel, I think I might have heard, did you have to drive?
Yeah, so my first flight was canceled. My second flight was canceled. I'm like at the airport and finally I'm like, all right. So I Ubered home, got in my car, drove through a snowstorm, and made it here in time for my talk today. And then we've got this very important recording. And then we're going to do a TWIP, This Week in Parasitism, and a This Week in Virology clinical update tomorrow morning. So a busy time ahead of me.
Wow. Well, I'm glad you made it safely. Wow. Yeah, I don't have anything exciting. It's only raining here. It hasn't gotten quite cold enough for it to be snow. So
well, it is
I'll
freezing,
take that for the time being.
freezing up here, and I have balanced the computer on top of several books of Mormon now, which has replaced the Bibles in the hotel rooms, and so try to keep it from teetering off.
Yeah, well, we'll try to get through before it teeters.
Okay.
Welcome everyone to another Puscast. References, as always, are available in our show notes at MicrobeTV, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, we'll start off with our viral section. Remember to listen to TWIV, This Week in Virology, where I will discuss the fact that I am up here in Canada, which has just lost its measles elimination status as of the day of recording. All right. Well, the article, High Prevalence of Varicella-zoster virus infection among persons with suspected Mpox cases during an Mpox outbreak in Kenya 2024, was published in the American Journal of Tropical Medicine and Hygiene. And I just do not know how long it will take to teach the old dogs new tricks. Remember, Occam was not a doctor, John Hickam was. You could have more than one darn thing at the same time. So Kenya is experiencing a clade 1b Mpox outbreak with 28 confirmed cases reported by the Ministry of Health from July to December 2024. PCR testing was done for VZV, varicella-zoster virus. Testing was also part of the differential diagnosis for Mpox, and a subset of cases were genetically sequenced. Of 277 specimens tested for Mpox. You ready for this? 61% tested positive for VZV, including instances of co-infection with both viruses in 4 cases. Genome analysis was used to identify clade 5, human, alpha herpes virus 3, and 8 of the genetically sequenced cases. Expanding lab capacity during this outbreak enhanced disease intelligence by confirming another etiology of rash among patients who tested negative for Mpox, underscoring the need for a broad differential diagnosis when diseases present with overlapping clinical signs and symptoms.
Nice. My first paper I pulled from CID, earlier initiation of treatment following HIV acquisition reduces non-AIDS defining malignancy risk. And so the authors here found that starting ART within 12 months of HIV acquisition resulted in an about 40% reduced risk of any non-AIDS defining malignancy and of infection unrelated non-AIDS defining malignancy compared with starting ART later. And so they had this national cohort, the Dutch Athena cohort, which are adults, and they were categorized as early ART if those ART drugs were started within 1 year of HIV acquisition. And so because of this kind of unique database, they had the ability to see seroconversion rates or kind of their previously negative testing. So there are about 20,000 people with HIV. 1,858 were considered early, and then the other right under 18,000 were in that late start group. Most of those in the early ART group were younger and had higher CD4 nadirs. And overall, there were 894 cases of non-AIDS defining malignancy, 25 of those in that early group, 869 in the late group. And so I pulled the numbers. Yeah, starting ART within 12 months prevented 17 cases during a median follow-up of 6.5 years. And again, this is a pretty young population, so perhaps those numbers are, overall higher. And they talk a little bit about potential mechanisms, like reducing accelerated immune senescence, sustained immune activation, but that also early ART may help promote clearance of oncogenic pathogens like HPV. So I thought was a nice one to pull out, and also just kind of a unique opportunity with that cohort to kind of define it the way that they did.
Excellent. Well, I have this article, and I've been talking about this a lot. The article, Impact of Vaccinating Adult Women Who Are HPV Positive or with Confirmed Cervical SIL with the 9-valent vaccine, a systematic review published in the journal Viruses. I'm going to leave in a link. There was a deep dive for this one on TWIV 1267, and I also dove into it on 1268. I won't leave a link in for that because we're basically going to cover it right here. So this is really exciting. The whole concept of a vaccine as a therapy for cancer. Okay, so infection with certain types of HPV, human papillomavirus, cause anogenital, head and neck diseases, including warts, precancerous lesions, and cancer. We estimate that almost all cervical cancer is due to HPV, and we'll leave in some links to this, and the majority of head and neck cancers are also related to HPV. So since we have a highly effective vaccine, almost all, if not all of these cancers could be prevented by vaccination. But this is where it gets really interesting. What about jumping in after the fact when a person did not get vaccinated but has the HPV infection and has already developed cancer? Can we use this vaccine therapeutically to help the body clear the virus? So based on the systematic review, they identified a number of cohort studies. They found that complete HPV remission was achieved in up to 72.4% of vaccinated women, compared to only 45.7% among unvaccinated controls. Vaccination after conization, right? So that's the removal of that interface that's affected. Vaccination after conization lowered the recurrence risk of CIN2+ lesions by 87%, with benefit seen regardless of timing. The most significant effect was observed when vaccine administration was performed before the surgical procedure. Furthermore, HPV vaccination notably enhanced viral clearance and decreased the likelihood of repeated surgical interventions. So pretty exciting, but what are the current CDC ICIP recommendations? So right now, here are the recommendations, and I'm also going to say the commentary that I will criticize. So, these are in line currently with ACOG, CDC, ACIP, American Cancer Society, IDSA, kind of all grouping together. So HPV vaccine is recommended for routine vaccination at age 11 or 12, but you could start as young as 9. ACIP also recommends vaccination for everyone through age 26, if not adequately vaccinated when they're younger. Now, there's a little bit of controversy, right? HPV vaccination is given as a series of either 2 or 3 doses. 2 might actually be fine, but that was something that was not particularly addressed here. Vaccination is, ready for this, not recommended for everyone older than age 26. Some adults, age 27 through 45, may decide to get the HPV vaccination through shared decision making. The whole idea here is that, these people, they've already been exposed to HPV, and what good would it be to vaccinate you after the fact? Well, we just had a nice study. So adults age 27 through 45, consider it. But here's what they say, which I'm going to criticize. Right now, they say, keep in mind that HPV vaccination prevents new HPV infections, but does not treat existing HPV infections or diseases. HPV vaccine works best when given before any exposure to HPV. Apparently not true. All right, moving into bacterial. Be sure to listen to This Week in Microbiology. If people haven't listened, the last one is great. It's all about like putting ants into your yogurt and using like their microbiome and some of the formic products, formic acids, to produce this wonderful yogurt. And then there's the other stuff about the microbiome of chocolate, making fine, high quality chocolates. I don't know if people are aware. I spent some time in Ghana where I got to see the whole process firsthand, where there's actually a fermenting process before you dry the beans. So, all right. So you might want to listen to TWIM if you want to figure out how to have some great yogurt and some really fine chocolate. All right, I see Sara getting ready to like leave the podcast and start listening to that right this moment. All right, the articles. Consequences of delaying surgical intervention in patients with native joint septic arthritis was published in Open Forum Infectious Disease. So early guidance is, hey, you got to get in there. You don't want to wait. But what's the data that drives that early intervention, early surgical debridement for native joint septic arthritis? These investigators conducted a retrospective multi-center cohort study of adults 18 or older with native joint septic arthritis, they give that an acronym, NJSA, who underwent surgery across Mayo clinical campuses between 2012 and 2021. Clinical outcomes at one door were assessed using a 9-level desirability of outcome ranking door scale, incorporating survival, treatment success, joint recovery. Among 268 patients, 30% underwent surgery less than 1 day from admission, right ahead. 47%, 1 to 2 days. 24% greater than 3 days. At 1 year, 57% achieved full recovery without unfavorable events. When treatment failure occurred in 34%, while treatment failure occurred in 34%, in unadjusted analyses, longer surgical delay was significantly associated with worse door scores, increased 1-year mortality, and treatment failure. Pretty substantial. So even after they did any adjustments. So yes, delayed surgical treatment is associated with increased risk of failure, mortality, and bad outcomes.
All right. I can't believe we only have one. That was our one bacterial article.
We're going to hit them heavy next time, Sara.
I know. Well, we usually are, particularly, but at least I usually put a lot of bacterial in. So I will kick off our fungal section. So I think many of us know that the benefit of adjunctive corticosteroids in non-HIV pneumocystis pneumonia is a little bit less clear. And I think you might be able to say controversial compared to HIV-associated, I'm going to say PJP, PCP, whatever people like to hear. I'll probably end up saying mix of both. So I pulled this recent publication from CHEST, Adjunctive Corticosteroid Use and Clinical Outcomes in Non-HIV Pneumocystis Pneumonia. And so here the authors point out to a pretty recent multi-center randomized trial published earlier in 2025, Lemiel, I think that's how you say, and et al. So I put a link here. So that study, it did not achieve its primary endpoint of reducing 28-day mortality, but they did find that adjunctive steroids were associated with lower rates of intubation and reduced 90-day mortality. So suggesting possibly a delayed survival benefit using steroids in non-HIV related PJP. So in this paper that I pulled today and that we're talking about, the authors are hoping to think a little bit more about that relationship between corticosteroids, the dose that is used, and outcomes, again, in non-HIV PJP. So this is a multi-center cohort study of hypoxemic, non-HIV immunocompromised adults with proven or probable PJP. They modeled corticosteroid exposure as a continuous, cumulative, time-varying dose administered during the 21-day follow-up period, and they truncated at the time of death or at day 21, whichever occurred first. their primary outcome was 90-day all-cause mortality, starting from that initiation of the anti-pneumocystis therapy. So there were 375 patients. The median age was about 66 years old, 59% were male, and as far as what type of immunocompromised, a little under a third, so 30% were hematologic malignancy patients, about 30% were patients with solid tumors on chemotherapy, and then kind of a mixture of other things, autoimmune disease, 17%, solid organ transplant, about 14%. About 80% of these patients were treated primarily with Bactrim or trimethoprim sulfamethoxazole. And 55% of patients were receiving some sort of what was considered chronic steroids before their PJP diagnosis. They found the overall 90-day mortality rate was 44%. Overall, 56% of patients were admitted to the ICU. And greater cumulative corticosteroid exposure was consistently associated with an increased risk of 90-day mortality in the study. And they did several types of sort of adjustments and analyses. They did not observe a benefit for some of the key respiratory outcomes. So meaning higher doses didn't seem to reduce the risk of subsequent intubation if they weren't intubated at baseline. And that didn't really seem to help those on sort of high flow nasal cannula and beyond to sort of come off of that support sooner. And so I mentioned they use these marginal structural models with daily inverse probability weighing, basically trying to tease out that, are the patients with underlying worse illness severity, more severe disease, longer, higher steroid doses, like trying to separate those out, which I think is usually the thing that folks are looking at. But, I think we won't talk too much more about it, but the sort of take home, right, is greater steroid exposure was associated with a higher 90-day mortality without an obvious benefit for things like preventing intubation or accelerating recovery. And they didn't show, as they looked at the sort of steroid dosing, that escalation of the steroid dosings provided any additional benefit. So I think this would be a really nice sort of pairing if folks took this paper and that the initial one I mentioned from earlier in 2025 for a journal club. And I think the idea being that there may still be some benefit in steroid, but it's not sort of clear what that dose should be if you're going to use perhaps a more modest dose, and not necessarily escalating those amount of steroids supplied to these patients will make a difference. And then I pulled, there's plenty of figures. I happen to just pull the Kaplan-Meier curve of the 90-day mortality as they group them by these steroid dosing quartiles, but encourage people to check out the paper.
Yeah, I like that figure. It looks like you might not be helping people out with those high doses.
Yeah.
All right. The article, nasal iodophore to reduce Candidozyma auris. Usually I'm kind of on board with the renaming. But
Are you?
I don't know. Maybe I'm not. So, nasal iodoform to reduce Candidozyma auris nasal carriage in nursing home residents, published in Open Form Infectious Disease. Come on. Candida auris is an emerging drug-resistant yeast that frequently colonizes the nose. Among 27 nursing home residents, 5 days of twice daily nasal iodophore reduced nasal carriage bioburden in 52%. With negative post-treatment cultures in 19%, providing hypothesis-generating evidence for the role of nasal decolonization in C. auris prevention. Now, this is actually, I'm hoping I'm going to sort of send this out because someone will hopefully jump on this, but one of our local nursing homes actually is now having a Candidozyma auris, Candida auris, issue where we're now having to screen every resident coming into the hospital from that facility. So maybe that would be a place to do this study.
And then I grabbed one other fungal paper. It's kind of up my alley. So from JPID's Epidemiology of Invasive Fungal Disease and Pediatric Heart Transplant Recipients. This retrospective cohort of 200 heart transplant patients at Cincinnati Children's and CHOP from 2012 to 2021 found proven or probable invasive fungal disease in 8 or 4% of these heart transplant recipients. All 5 cases of proven invasive fungal infection occurred within 30 days of transplant. These were considered early onset in all those 5 cases. 4 of those were Candida or yeast. The all-cause mortality among the cohort overall was 11.5% in the first year. In those with invasive fungal infection, all-cause mortality was 50%, with 3 cases mortality attributable to fungal infection and 2 cases dying while on active treatment. And the other sort of takeaway is they found the need for ECMO, longer time requiring central venous access, longer time to chest closure, and receiving a significant amount of broad spectrum antibiotics was associated with early onset invasive fungal disease.
All right, I love this next one. The article, Mapping the Geographic Distribution of Dimorphic Mycoses Using a U.S. Commercial Insurance Database, published in OFID. So the gist was there were 37,513 histoplasmosis, 14,987 cocci, and 2,207 blasto diagnoses during the 2007 to 2016 within the 387 metropolitan statistical areas. The DMs, the dimorphic mycoses, were consistently diagnosed outside their historical hyperendemic regions. Time to update the boards and the teaching. Let us look at those figures. Is it ever going to happen? How many times are we going to have to show this data? So the first figure, and they have different parts to it, are the 10-year cumulative incidence per 100,000 Medicare beneficiaries. And this is for blasto, right? And so you see this 1955, what is that? Ohio River Valley? Is that what people used to say?
Mm-hmm.
And then you can see the truth. Quite different, right? It's all, you got tons out there in California and what is that? Nevada out there. So really a lot of cases outside. Then the next you move into these really nice, very similar figures, geographical distribution of histoplasmosis, and sort of see what they tell us. And then you see, again, tons of histo on the West Coast, right? And actually, it's sort of interesting. You're getting this sort of hotspot areas as well when you look at that. And then they've got some really nice geographic distribution of cocci. That's just in the Southwest, right? Well, it may be a hotspot in the Southwest, but I'm seeing a little bit of a hotspot up in the Washington area, the great state of Washington area up there by the Puget. How does that sound? So one of the things I want to throw in, which makes this even worse, is that these are not reportable in every single state. So when you look at this map and you take away, hey, we're seeing it outside the endemic area, there probably are a lot of areas where it's going on, it's even being diagnosed, but it's not reported. And then it's probably being underdiagnosed because people aren't thinking about it because they don't think we have it there. All right. Well, I was going to put this kind of with the other one, but then it was going to mess up my figures. So we're back to Candida auris. Can't mess with my figures. So this is also going to come up in our miscellaneous section. We're going to be talking about, you ready for this? Just maybe the bots can get ready. Climate change, climate-dependent trends. Yes, we believe in climate change. Genomic dynamics of the emergent Candida auris, exploring climate-dependent trends, published in Open Forum Infectious Disease. Lots here, but a take-home was their finding that the interaction between climatic variables showed a strong association with the presence of resistance genes, evidencing the multifactorial nature of climate change in shaping pathogen adaptations. These findings emphasize the influence of climate variables on the resistome of C. auris, which is crucial for predicting the spread and resistant patterns of C. auris as climate change continues. All right, parasitic. So we've got a bunch of good This Week in Parasitisms coming up. We're going to have a special guest when we record tomorrow morning talking about malaria. And also we got some really cool mystery cases out there. All right, we're going to start here with the article Evaluation of a One Health Public Health Program Based on Minimum Inputs to Control Taenia solium in Madagascar, published in PLOS NTDs, right? So cysticercosis in humans caused by the parasite Taenia solium is one of the WHO's NTDs. It's really high on our list because of neurocysticercosis and seizures. So here they describe a large-scale minimum inputs T. solium control program implemented at a public health program in Madagascar. So what are they doing here? So you're going to be doing stuff to pigs, you're going to be doing stuff to people. Initially, all pigs were vaccinated and pre-medicated, after which only young piglets and pigs imported into the program area were targeted for interventions. After piglet interventions were in place and ongoing, a single mass drug administration was delivered to the human population with this is a new one for probably our listeners, a teniocide. Coverage of the eligible human population by the MDA, Mass Drug Administration, was 62.5%. Prior to the intervention, 30.8% of slaughter-aged pigs had viable T. solium infection, reduced to 8% after the program. Human teniasis was found to be 1.25% prior to MDA and 0.6% 1 year after the MDA. So I was curious about this reference to the teniocide. And we read that the main drug used was praziquantel, and this was donated. Now, as MDA with Mass Drug Administration with praziquantel was already part of the Ministry of Public Health's annual program for treatment of schistosomiasis, the MDA was conducted by the Ministry of Health, Public Health, in synergy with their MDA program against schistosomiasis, right? So this wasn't as clean, right, if you think about it. So children age 5 and 15, age 5 to 15 of age, were targeted by the schistosomiasis program. They're getting the praziquantel at 40 milligrams per kilogram. Additionally, children in the Batafo district also received mebendazole as part of the Ministry of Public Health program to control soil-transmitted elements. So we got a bunch of sort of background of Mass Drug Administration of anti-helminthic drugs, anti-parasitics, teniocides, as they call them here, but really seeing this nice One Health approach where they're looking at vaccinating and treating the pigs, and also this Mass Drug Administration for the humans.
Yeah, I had definitely not heard or used teniocide before. Well, I grabbed this next paper I thought was really cool. Transplacental transfer of lumefantrine, mefloquine, and piperacin, a comparison of concentrations in mothers, neonates, and cord blood. This was in CID. So malaria in pregnancy is associated with increased mortality for both mother and fetus. It's especially unfavorable in placental malaria. And so the falciparum parasites can sequester in the placenta and basically cause kind of like a mechanical obstruction to the microcirculation and change the placental pathophysiology, ultimately leading to placental insufficiency and affecting the baby with intrauterine growth restriction. And so congenital malaria, which is the detection of parasites in cord blood or the newborn circulation in the first 7 days of life, has an estimated overall prevalence of 6.9% in malaria endemic areas, which I actually didn't know that percentage before reading this, but honestly, it was actually a little bit higher than I think I was expecting. And so in this paper, authors looked at a triad of blood samples, so mother and neonatal capillary blood and cord blood. They looked at these blood samples at delivery or I think within an hour or so of delivery among 90 women near the Thailand-Myanmar border who were treated for uncomplicated malaria with one of the 3 combo drugs, so artemether lumefantrine, artesunate mefloquine, or dihydroartemisinin piperacin. It's a mouthful. So 4 to 8 weeks before delivery. The drug concentrations of these drugs and their key metabolites were then examined, and they were found detectable in neonates at birth at a maximum of 27, 42, and 55 days after the first dose of lumefantrine, mefloquine, and piperacin, respectively. So all of the antimalarials permeated the placenta and remained in the fetus for at least that, 4 to 8 weeks after maternal treatment against malaria. But the ratios of how much drug got to baby was quite variable. So piperacin had the highest neonate to mother ratio with basically near maternal equivalence. So similar amount of drug. Others ranged from, kind of less than half or worse. And actually, lumefantrine and its metabolite was actually so low in some of the samples, they really couldn't analyze it. And then they found that blood concentrations were higher in mother, followed by neonate, and lowest in cord blood. And so the cord blood is exclusively fetal. It comes from the veins draining the placenta. And then neonatal blood is like a heel prick, so capillaries. And so the authors, suggest reasons for that lower fetal versus maternal concentration may be a combination of things like the drugs being highly protein bound and lower levels of proteins in fetal blood. It's not really clear why neonatal and cord blood differed as much. They put out some ideas such as hemoconcentration and accumulation of the antimalarials in red blood cells. And that really is just the different vessels sampled might be a contributor to why they saw those differences. But I thought this was really interesting. There hasn't really been a lot of investigation into antimalarials and transplacental transfer. There are kind of similar studies that look more at HIV, ART transmission as far as mother and neonate. But we can obviously see the importance of studying drug concentrations in baby. And the other sort of takeaway was that cord blood didn't really seem to be a suitable substitute for newborn blood, which I think was sort of an assumption that sometimes is thought of with these other studies, but didn't seem to hold true in this paper. So very cool. I'm biased because all the papers I pull are kind of med peds and baby and adults. I love any combo, but very, very interesting. Oh, and I totally forgot. I did grab figure 1, which just shows these drug concentrations in the neonate and cord blood samples over time. So they have like a darker line for the neonate and kind of a light gray for the cord. And you can see it by drug and its metabolite.
Very cool.
Okay, so I will bring us into our miscellaneous section. I just pulled one quick paper from OFID, Amplifying Our Voices, Fostering Advocacy in Infectious Diseases Fellowship. This paper took some ideas that were generated from the ID training program directors meeting in 2024, really on, it sounds like their discussion of how advocacy is and should be incorporated into ID fellowship. And so there's kind of one mega table that looks at examples of how ID fellowship program directors can involve trainees in advocacy. And, it says for program directors, but really could be for anyone who is involved in working with fellows or their fellowship program. And they also note 2 areas where program directors can serve specifically as advocates on behalf of trainees with workplace well-being and leaves of absence. So it's a really quick read. Hopefully folks can check it out and, think about and share how they use advocacy and incorporate it into their fellowship program.
All right. Fantastic. All right. Well, I really like this. It's one of those where you have like several children and they're all your favorites. So this is also my favorite. And it's the article, Plant-Based Diets and Climate Change, A Perspective for Infectious Disease Providers, also published in Open Forum Infectious Disease. I mean, Open Forum Infectious Disease has gotten to be so good. I feel like I could just read that one journal. But no, okay. Keep reading all the others, by the way. But, this is one of those ones that's like so good. You start chatting about it, with like your family, and they're actually really interested. So let me just start by reading the abstract. So Global climate change driven by human activity is a pressing concern. Recent medical literature highlights the negative consequences of climate change on human health, including changing patterns and rising rates of global infectious diseases. Livestock production and animal agriculture are large contributors to greenhouse gas emissions, and rising rates of antimicrobial resistance are propagated by antibiotic use in livestock feed. Despite this, the global demand for animal-based food production continues to rapidly grow. Furthermore, meat consumption is linked to negative health consequences, while plant-based diets provide health benefits that are endorsed by multiple medical associations as part of a healthy lifestyle. Healthcare providers, including infectious disease physicians, are in a privileged position to provide dietary counseling. This review advocates for the adoption of plant-based diets as a dual strategy to combat climate change and improve health outcomes, particularly in the context of infectious diseases. Now, some really interesting figures, and again, some new terms here, Sarah. So,
Yeah.
I had never really used the term pollotarian, and I think that's the way, because they're using the pollo, right, from the Spanish. So you've got your vegans, right? And they're just vegetables, nuts, basically no eggs, nothing, no dairy, nothing no animal products. Then you got your lacto vegetarians and your ovo vegetarians, right? So you're adding what you add. So lacto is adding milk and ovo is adding eggs. Lacto ovo vegetarians adding both. But then you raise this pollo vegetarian or pollotarian, and they actually add chicken to it. And then they could be lacto, ovo, pollo vegetarians if they add that. I guess the conversation came up with, so why are you okay eating chicken, but then you're not going to eat the eggs? And then they also brought up dairy, which I pointed out comes from cows, not chicken. So I'm okay with you being a pollo, whatever. And then pescatarian, we know that. And then there's the flexitarian. That also was new for me. So these folks are kind of like, yeah, I'm sort of trying to, avoid, animal-based products. But, if you serve it to me, so kind of interesting. And then this is also, you can see kind of like, they doom and gloom, right? That's where we're always going. But you can see the doom and gloom with land use over time. And you can just see like really incredible growth of grazing land over time. Also, I was really shocked by this. 31% of greenhouse gases they're attributing to livestock and fisheries. And then another chunk with all the supply chain of getting those all over the place. And I think we're all familiar with the amount of antibiotics used in animal-related food production. Talk about some of the other aspects as well. And then they talk about, so what are the barriers and possible solutions, right? Because now we're going to read this article, we're going to drink the plant-based Kool-Aid. And then why are we not all going to make this a better world? And so they talk about a lack of physician training, right? And it is true. I don't know if we really get a lot of nutrition education in our medical training. And I know there's a lot of efforts to change that. And they also have a link into some free CME courses, nutritioninmedicine.org, some Stanford courses. They talk about price barriers or advocate access. Actually, seeming like a plant-based diet might actually be cheaper. I mean, my initial foray into plant-based foods was sort of monetarily driven when I was back in college, living on basically rice and beans, which are cheaper than some of those animal-based products. Also, social and cultural concern for adequate nutrition content. And I think that's a myth here, right? There's so many people that are like, oh my God, you're on a plant-based diet, you're never going to get enough protein, and they're sort of desperate to feed you chunks of meat. And I think, we should know better. But also taste preferences and and I think probably the biggest is a lack of exposure to plant-based diets. And as we're seeing increased exposure to healthy, tasty plant-based diets, such as at hospitals and other, plant-based menus, we may see growth in this. So I leave on that plant-based diet note.
I've learned lots of new words today. Tiny side, and flexitarian are the top of Sarah's words for the day. So,
Did you know poetarian? Was that something? Is that just
no,
new to
I
me?
didn't. Well, I didn't know there was a term for it, but I feel like my mom sort of did a version of that. She never called herself that.
Okay.
But anyway, now I can suggest it. Well, that brings us to the end of this podcast. As always, the references for this show are available at MicrobeTV, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube, where you can subscribe, like us, ring the bell, and leave some nice comments to sort of dilute out the bots. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute. Or right now, we're in our big Microbe TV fundraiser. So go to parasiteswithoutborders.com, click on that donate button. We're hoping to double your donations to get up to a maximum donation of $20,000 to support Microbe TV.
I'm Sarah Dong. You can find me on Blue Sky at SarahWinDong or at febrilpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.